So, like I mentioned, ASHA requires clinicians to be culturally competent and responsive. Cultural competence is a dynamic and complex process requiring ongoing self assessment, continuous cultural education, openness to others' values and beliefs, and willingness to share one's own values and beliefs. Cultural responsiveness is understanding and appropriately including and responding to the combination of cultural variables and the full range of dimensions of diversity that an individual brings to interactions. Cultural humility is understanding that one must begin with personal examination of one's own beliefs and cultural identities to better understand the beliefs and cultural identities of others. ASHA says clinical approaches such as interview style, assessment tools, and therapeutic techniques that are appropriate for one individual may not be appropriate for another. It's important to recognize the unique influence of an individual's cultural and linguistic background that may change over time and according to circumstances. ASHA has several roles and responsibilities related to this. SLPs must practice in a manner that considers the impact of cultural variables as well as language exposure and acquisition on the individual and their family. They must practice in a manner that considers each individual's cultural and linguistic characteristics and unique values so that these professionals can provide the most effective assessment and intervention services. They require that SLPs have met academic and professional standards that include knowledge of cultural variables and how they may include communication and service delivery. We're required every year or every 3 years when we take our continuing education or professional development hours. Some of these hours have to be in about cultural and linguistic diverse populations. It requires responsiveness to the cultural and linguistic differences that affect identification, assessment, treatment, and management, and that we advocate for consumers, families, and communities at risk for or presenting with communication and related disorders and/or differences. Additionally, they provide guidance on distinguishing between communication differences and communication disorders. So we have to recognize that cultural dimensions and individual variation may influence things like eye gaze, facial expressions, body language, social rules. In some languages, it is considered really rude to point with one finger. So I know at Disney World, if you asked a person that works at Disney World where the restroom is, they may point with their whole hand or two fingers. Some languages or some cultures, it's rude to look people directly in the eye. So we have to consider these things when we are evaluating and working with our clients. We have to review cultural and linguistic variables and factors that can influence their communication. So if we have a student come to us whose first language is Vietnamese, it's our responsibility to look up those factors that may influence their communication. What sounds do they have in Vietnamese that we don't have in English and vice versa? And how might that impact their language? Things like that. We have to determine if the communication pattern is related to their linguistic background. Is this related or is it not? Because if it's not related, then it could be a communication disorder. We have to understand that differences may be related to the amount and types of different exposure and development of new cultural communication patterns. So, how long have they been exposed? How long maybe have they even been living in the United States? We have to recognize that assimilation and level of acculturation may influence their communication patterns. So, if they're trying to assimilate and fit in with their new culture, we have to identify a disorder as a breakdown in communication that is sufficient to negatively influence the effective use of the language. We have to identify a communication difference as a variation of a symbol system used by a group of individuals that reflects and is determined by shared regional, social, or culture ethnic factors. So just because someone in the South calls a sweetened carbonated beverage Coke, and we're evaluating them in Chicago where they call it pop, that is a dialectical difference, right? That's a communication difference, not a disorder. We have to recognize that a regional, social, or cultural ethnic variation of a communication system is rule-based and should not be considered a disorder. Um, and we have to incorporate the cognitive learning styles of individuals and avoid the expectation of mainstream methods for problem solving and communication. So, again, ASHA requires us to be culturally responsive and culturally competent. And so, it's really important that we understand second language acquisition, dialects, accents, because we are going to encounter populations who English is their second language or that are from different dialects. And again, it's up to us to be competent.